Good morning, all. So, once again, let's start the remaining chapter part of antihypertensive drugs. So, once again, I am explaining you about the learning outcome of this chapter. That is, at the end of this lecture, the student can learn about a physiology of blood pressure, hypertension, pathophysiology of hypertension, and pharmacology of hypertension. So in our last lecture, we have already discussed about the physiology of blood pressure, hypertension, and pathophysiology of hypertension. Now, let's discuss about the pharmacology of hypertension. So first of all, let's discuss about the various blood pressure conditions. A normal blood pressure of our body is 120 systolic pressure and 80 diastolic pressure. At the pre-hypertension stage, it would be between 120 to 139 systolic pressure and 90 to 99 diastolic pressure. At the hypertension stage 1, the, the blood pressure would be level in between 140 to 159 systolic pressure and 90 to 99 diastolic pressure. In case of hypertension stage 2, our blood pressure would be more than 160 systolic pressure and 100 diastolic pressure. In case of emergency, a blood pressure would be more than 210 systolic pressure and more than 120 diastolic pressure. In case of resistant hypertension, a failure of blood pressure control with the drugs. Now let's discuss how can we treat hypertension. A secondary hypertension treat by underlying causes. Essential hypertension causes not known. Factors involved stress, weight, dietary habits, salt retention, increased angiotensin production, increased sympathetic tone. Approaches a reduced salt or water content of body, reduce sympathetic tone, reduce effects of circulating angiotensin 2, reduce cardiac force of contraction, dilate peripheral vessels to reduce cardiac filling and consequent stroke volume. Drugs used for treatment of hypertension: diuretics, central acting agent such as methyl-dopa clonidine, beta adrenergic blocker, alpha adrenergic blocker, combined alpha and beta blockers, ACE inhibitors, angiotensin receptors blockers such as hydralazine, minoxidil, diazoxide, phenoldiazepam. On the other classification, sodium nitrosoppresside. Apart from angiotensin receptors blocker, calcium channel blockers, vasodilators. Apart from this one, a need for lifestyle changes, weight loss and control, restricted sodium intake, increasing aerobic exercise, moderating alcohol consumption. These changes in lifestyle may be sufficient to control hypertension in early stage 1. They also facilitate pharmacological treatment. So let's discuss about the first class of the antihypertensive drugs, that is diuretics. Examples are thiazide, loop diuretics, and potassium sparing diuretics. They are antihypertensive when given alone. Also enhance the efficacy of other antihypertensive agents. Exact mechanism unknown. Initially decrease extracellular volume and enhance sodium excretions by inhibiting sodium and calcium cotransporter, which leads to a reduce in cardiac output. Long-term therapy, cardiac output and extracellular volume returns to pre-treatment value due to compensatory mechanisms, but antihypertensive effect persists due to decrease in peripheral vascular resistance. Decrease in peripheral vascular resistance may occur due to direct vasodilatory effect of thiazides or due to their effect on kidney. Thiazide should be avoided in patients with concomitant diabetic mellitus, gout, hyperlipidemia, and renal insufficiency. High efficacy diuretics, that is also calling as a ceiling diuretics. Severe reduction in blood volume and electrolyte imbalance. Strong diuretic, weak antihypertensive, then thiazide diuretics. Indicate in hypertension when complicated by chronic renal failure, coexisting congestive heart failure, severe edema due to use of potent vasodilators. Sympatholytic or agents, that is centrally acting, example alpha methyl dopa or clonidine. Beta adenoreceptors blocker, alpha adenoreceptors blockers, combined alpha and beta adenoreceptors blocker, that is labetalol carvedilol. Methyl dopa, it is an analog of dopa. Dopa is a dihydroxyphenylalanine. It is a prodrug metabolized in brain by L-aromatic amino acid decarboxylase in adrenergic neurons to alpha-methyldopamine and then converted to alpha-methyl norepinephrine. Alpha-methyl norepinephrine is stored in the vesicles in place of norepinephrine and released in response to stimulus. Acts in the central nervous system to reduce sympathetic outflow from the brain stem. Also probably acts an agonist of central presynaptic alpha-2 receptors to reduce central sympathetic outflow. It's rapidly absorbed. T half-life approximately 2 hours. Even after intravenous injections, effects start after a delay of 6 to 8 hours. Clonidine, guanabang, and guanafacine stimulate alpha-2A subtypes of alpha-2 receptors in the brain stem and reduce the central sympathetic outflow. It reduces in plasma concentration of norepinephrine, correlates with the decrease in blood pressure. Decreased sympathetic outflow also reduces cardiac output and heart rate. In supine positions, when the sympathetic tone is to vasculature is low, the effect is mainly by reducing heart rate and stroke volume. In upright position, the vasculature tone is high and effect is mainly by reducing the peripheral vascular resistance, since they block peripheral vasoconstrictions, postural hypotension may occur. Now let's discuss about adverse drug reactions or sedation, xerostomia, dryness of eye, nasal mucosa, parotid swelling, postural hypotension, erectile dysfunction, bradycardia, sinus arrest, AV block, and rebound hypertension. Guanadril, exogenous false neurotransmitter, actively transported to adrenergic neuron by norepinephrine transporter. Previously, norepinephrine transporter was known as uptake 1. It stored in adrenergic neurons where it is concentrated in storage vesicles and replaces norepinephrine released in place of norepinephrine and act as false neurotransmitter. It has no activity on adrenergic receptors. This inhibits the functioning of peripheral adrenergic neurons. Antihypertensive effect is achieved by reduction in peripheral vascular resistance, a postural hypotension. Beta-adrenergic blockers decrease heart rate, output, and stroke volume by blocking beta 1 receptor, inhibit renin release from juxtaglomerular apparatus by blocking beta 1 receptor, block beta receptors of peripheral blood vessels so they constrict by blocking beta 2 receptors. Peripheral vascular resistance increases initially but gradually returns to pre-treatment values or less. Those crossing the blood-brain barrier also reduce central sympathetic tone, do not cause retention of salt and water, often combined with diuretics additive effect. Highly preferred drugs for hypertensive patients with complications like angina, myocardial infarctions, and congestive heart failure. Beta adrenergic blocker produces decreased myocardial contraction and cardiac output by blocking beta 1 receptor, decrease renin secretions by blocking beta 1 receptors, decreased central sympathetic activity by blocking presynaptic beta 2 receptors. All beta adrenergic blockers produces reduced exercise tolerance, mild chronic fatigue, sedation, increased airway resistance, bradycardia, sleep disturbances due to that reduced melatonin release. All beta adrenoreceptors blockers initially produces vasoconstrictions by blocking vascular beta receptors that relax vascular smooth muscles. This vasoconstrictions disappears after some times. Beta adrenoreceptor blockers with intrinsic sympathomimetic activity. Advantages: less bradycardia and myocardial suppression. Useful in patients having low cardiac reserve. Less likely rebound hypertension, less worsening of lipid profile, less effect on exercise tolerance. Beta adrenoreceptors blockers with intrinsic activity. Examples of the drugs are oxyprinolol, pindolol, nebutalol, and acebutolol. Nebutalol, it is a beta 1 selective antagonist, promotes vasodilation due to increased production of nitric oxide in arterial smooth muscle. It has a antioxidant properties also. Alpha 1 beta adrenoreceptors blockers. It blocks alpha 1 adrenoreceptors on smooth muscles of arterioles. reduce arteriolar resistance, and increase venous capacitance. It reflects increase in heart rate and plasma renin activity. Return to normal during long-term therapy. Postural hypotension may occur depending on plasma volume. Reduce total plasma concentration of triglycerides and LDL. Increase plasma level of HDL, that is a beneficial effect. Effect on lipids persists even when combined with diuretics. Preferred in hypertensive patient with BPH. Combined alpha and beta adenoreceptors blockers, labetalol, carvedilol. Labetalol is a mixture of four stereoisomers. One isomer is alpha blocker like prazosin and is a non-selective beta blocker with partial agonist activity like pindolol. Two other isomers are inactive. Carvedilol is a beta receptor antagonist with alpha 1 receptors blocking activity and pheochromocytoma. Vasodilators, that is a hydralazine, directly relax the arteriolar smooth muscle. Mechanism are uncertain, does not relax venous smooth muscle, compensatory reflex increase in sympathetic outflow, increase in heart rate, cardiac output, plasma renin activity, and fluid retention. Selective decrease in vascular resistance in coronary, cerebral, and renal vascular beds. Postural hypotension uncommon because it does not dilate veins. Adverse drug reactions, extension of pharmacological effects such as headache, flushing, hypotension, palpitation, tachycardia, dizziness, and nausea can precipitate angina or myocardial infarctions due to increased myocardial oxygen demand. Immunological reactions, drug-induced lupus syndrome, serum sickness, and hemolytic anemia. Pyridoxine responses, polyneuropathy, probably because hydralazine combines with pyridoxine to form hydrazole. Minoxidil converted in liver to active form, minoxidil nitrate, and O sulfate. reduces arteriolar vasodilation, no effects on venous capacitance vessels, causes increase in cardiac output, blood flow to skin, skeletal muscles, gastrointestinal tract, and heart is increased. Dilates renal artery. Net effects depend on hypotension and extension of dilation. Potent stimulator of renin secretion by increasing sympathetic outflow, affecting renal regulation of renin release, minoxidil sulfate, open ATP modulated potassium channels, a potassium efflux occurs and cell is hyperpolarized, may precipitate severe bradycardia or sinus arrest. Hepatotoxicity, COMS test, that is antiglobulin test, necessary because autoantibodies are produced against Rh antigen. Preferred drug for treatment of hypertension during pregnancy. Adverse drug reactions on cardiovascular system same as hydralazine. Hypertrichosis, that is abnormal hair growth in the body may occur, and the uses are in treatment of severe hypertension should never be given alone, always with a diuretic to prevent fluid retention and a sympatholytic drugs to control reflexes, cardiovascular system changes, baldness, that is through the topical route. Thiaz- Thiazoxide, a chemically related to thiazide diuretics but has no diuretic activity. Instead of it, it causes retention of sodium and water. It acts by opening potassium channels in arteriolar smooth muscle cells, no effect on no effects on venules, causes hyperglycemia, used for short-term treatment of hypertension emergencies, often combined with diuretic and a beta blockers. Tenlodopam, agonist of dopamine D1 receptors, causes dilation of arterioles and natriuresis. Oral bioavailability is poor. T half-life approximate 5 minutes. Onset of action is rapid. Increased renal output, creatinine clearance, and sodium excretion. So, concomitant use of diuretic or beta blocker is not required. Adverse drug reactions are reflex tachycardia, headache, and flushing. Increases intraocular pressure, so should be avoided in glaucoma. Sodium nitrosuproside releases nitric oxide, which dilates the blood vessels. Mechanism of nitric oxide release not known, but mimics endogenous nitric oxide release by vascular endothelial cells. Nitric no development of tolerance dilates both arterioles and venules. Cardiac outcome falls due to venous pooling and reduction in peripheral vascular resistance. Plasma renin activity increases. Unlike arteriolar dilators hydralazine, minoxidil, and diazoxide, it causes only modest increase in heart rate and reduce cardiac outcome demand, cardiac oxygen demand. Used to treat hypertensive emergency, aortic dissection, controlled hypertension during anesthesia, effects on light on drugs, toxicity, headache, nausea, vomiting disappear after the drug is discontinued. Cyanide or thiocyanate accumulation, thiocyanate toxicity, psychosis, disorientation, and convulsions. Methemoglobinemia due to cyanide. Administration of sodium thiosulfate and hydroxycobalamin. Sodium thiosulfate acts as a sulfur donor and facilitates metabolism of thiocyanates. Hydrocobalamine combines with cyanide ion to form non-toxic cyanocobalamine. Pregnancy, if taken before pregnancy, most antihypertension can be continued except ACE inhibitor and angiotensin II receptors blockers. Methyl-dopa is most widely used for hypertension during pregnancy. Beta blockers are not recommended early in pregnancy. Drugs to be avoided for treatment of hypertension associated with other diseases. In case of pregnancy, ACE inhibitor, that is a angiotensin converting enzyme inhibitor, ARBs, such means angiotensin receptors blockers, beta blockers, diuretics. In case of diabetes mellitus, diuretics and beta blockers, In case of angina pectoris, vasodilators. In case of bronchial asthma, beta blockers. In case of peripheral vascular disease, beta blockers. In case of congestive heart failure, calcium channel blockers except amlodipine, alpha and beta blockers. So like that, we have completed our antihypertensive drugs which we are using for the treatment of hypertension. Now let's discuss about the quiz. So first question is, all of the following are normally involved in the pathogenesis of heart failure except, so the four options are: a cardiac lesions that impairs cardiac output, B, an increase in peripheral vascular resistance, a C, a decrease in preload, a D, an increase in sodium and water retentions. So the correct answer is C, that is a decrease in preload. Second questions, all of the following are compensatory mechanisms that occur during the pathogenesis of congestive heart failure except: A, an increase in ventricular and diastolic volume, B, an increase in the concentration of plasma catecholamines, C, an increase in vagal tone, and D, increased activity of renin-angiotensin alpha aldosterone. So the correct answer is C, that is an increase in vagal tone. Next question, all of the following agents belong to cardiac glycosides except: option A, digoxin, option B, streptozin K, option C, ambrinolone, and option D, digitoxin. So the correct answer is C, that is a ambrinolone. Next questions, the non-glycoside positive inotropic drug is: option A, digoxins, option B, stropanthin K, option C, dobutamine, and option D, digitoxin. So the correct answer is C, that is dobutamine. Next question, sugar molecules in the structure of glycoside influence. So the correct answer is four, four options are: cardiotonic action, pharmacokinetic properties, toxic properties, and all of the above. So the correct answer is B, that is pharmacokinetic properties. Next, a glycan is essential for, out of four options, first, plasma protein binding, B, half-life, C, cardiotonic action, and D, metabolism. So the correct answer is C, cardiotonic action. Next question, choose the derivative of the plant foxglove, that is digitalis. Four options are as follows: A, digoxin, B, streptozin K, C, dobutamine, and D, amrinone. So the correct answer is A, that is digoxin. Next, all of the following statements regarding cardiac glycosides are true except: A, they inhibit the sodium potassium ATPase and thereby increase intracellular calcium in myocardial cells. B, they cause a decrease in vagal tone. C, children tolerate high doses of digitalis than do adults. D, most frequent cause of digital intoxication is concurrent administration of diuretics that deplete potassium. So the correct answer is B, that is they cause a decrease in vagal tone. Last question, an important action of digital is to increase vagal tone. It is true or false? So it is true. So these are the references for this antihypertensive drugs. So like that, in this chapter, we have discussed about the basic physiology of blood pressure. What are the blood pressure? What is the normal level of blood pressure that we discussed in this topic. Next, we discussed about the pathophysiology of hypertension. Third, we discussed about the various pharmacological actions of the antihypertensive drugs, classifications of various antihypertensive drugs. Then we discussed about the therapeutic uses, adverse effects, toxic effects, contraindications, that all we discussed from these antihypertensive drugs. So now I'm finishing this lecture. Thanks a lot.